Welcome everyone to Healthcare for All, brought to you by WCANradio.com. This program examines the issues of healthcare for you. Join us now in the studio where the program is in progress.
And I'd like to welcome you to the studios of WCAN Healthcare for All. My name is Eric Meadows, and tonight's show is being hosted by Debbie Silverstein. And Debbie, I want to welcome you to WCANradio.com and this maiden voyage of this program. It's the first time. Welcome.
Thank you, Eric. I'm really excited to be here tonight, especially on the maiden voyage. This is a new career path for me.
So. Well, that's excellent. We're glad that we were able to offer this opportunity. I also want to introduce your guest, Dr. Johnathon Ross. We want to welcome you to tonight's show.
I'm delighted to be here.
Great. And I want to get into it right now. Let's talk about Ohio healthcare. Let's talk about healthcare for all.
Well, where do you want to start? I mean,
you have been a major player in SPAN Ohio, which is sponsoring this broadcast,
Sure.
And that's the Single Payer Action Network of Ohio. You are a past president of Physicians for a National Health Program. What led you to come to the conclusion that we needed a Medicare for All type system in this country?
How long a shaggy dog story do you want? When I went to medical school, no one talked about money. No one. Everybody knew doctors did pretty well. They made plenty of money, but no one talked about it. No one talked about how the money flowed through the system or how it worked at all. And that left me kind of curious. When I got done with my training, I'm an internist. I take care of adults. I do general care for adults, and I teach other doctors to be an internist like myself in Toledo, Ohio. But when I got done with my training, I was still curious about that. And I went back and I got a master's in public health in health administration and policy from the University of Michigan. And right about that time, this was when I finished my training, was in the early 1980s. And my hospital, which was sponsored by the Grey Nuns of Montreal, it's a Catholic hospital, almost 600 beds, does tertiary care, heart surgery, all that sort of stuff. We were in the middle of economic poor times again, and there was a threat to cut the payments for Medicaid, which is the program for poor Americans, pretty much back to the Stone Age here in Ohio. And at that particular time, there was money that was being offered to institutions that were willing to begin what were called HMOs, health maintenance organizations or managed care organizations. And my Catholic hospital decided that they wanted to form one that would include poor folks who are on Medicaid, and there was money available to do that, and it was the grant money to get that started. The hope was that by organizing healthcare through this managed care approach, that money would be saved and we'd be able to provide better benefits. Well, the state eventually passed a surtax on the state income tax. I think it was the income tax that covered the Medicaid deficit that was there, so that it never came to pass that there was this big hole punched, because it could have threatened the survival of our hospital at that time. But they did form the HMO, and I became the medical director of it. So for about 10 years, I worked in the insurance industry as a medical director for an HMO in Toledo, Ohio. And what I learned is if you weren't willing to be as low down, dirty dog, slimy as all the other insurance companies, you would get your head handed to you in the market. And the basics of it, and this is the simple concept that every insurance company understands, is that 10% of the people generate 70% of the healthcare costs.
Really?
Yes. So,
well, Dr. Ross, let me ask you this. I mean, insurance it's a necessary thing.
Yeah, absolutely, because healthcare has become expensive enough that it's almost impossible for somebody of ordinary means to afford the life-saving things that we can do now. But remember, if you're an insurance company and 10% of the people generate 70% of the healthcare costs, and you're getting an average payment from each of those people, right? Mm-hmm. Do you want any of that 10%?
Not at all.
Not at all. You want money for nothing.
Yes.
Right, and that's the other 7. That's the other 7.
And the saying goes that I want my insurance, but I hope not to ever have to use it.
Right. Well, that's the patient's attitude, but the insurance company's attitude is they want to make sure that you're healthy enough that you never will use it.
The thing is, when you're talking about insurance, that is the attitude you have most of the time towards auto insurance and homeowners insurance. Mm-hmm. And you can go through life and never make a claim on your homeowners insurance and never make a claim on your auto insurance. But there aren't any of us that are going to go through life without ever making a claim on our health insurance. And unfortunately, it works against us the same way making a claim on auto and home do.
You know, and so for years in this country, the insurance companies, the basic game, and this is what I learned when I was part of that insurance industry, is to avoid sick people. And we had all kinds of crafty ways, even within a 501c3 charitable HMO sponsored by Catholic nuns, to avoid sick people. And that's the hard, cold facts. Because if we didn't, if we just opened up our loving arms and said, y'all come, then we would have been handed our head in the marketplace. There's no way we would have been able to afford to stay in business if we took more than our share of that 10% that generates 70% of the cost.
Well, but, you know, today people say, well, if you're sick, just go to the emergency room. You know, they have to treat you. They can't send you away. So, in essence, isn't everybody covered?
Yeah, if you want to consider it that, it's a lousy coverage. And, of course, if you have any assets at all, the hospitals can come after you. You know, just because you go there and they do take care of you, they won't put you out the door. There's actually a law sponsored by Congress in the mid-1980s, actually signed by Ronald Reagan, called EMTALA, the Emergency Treatment and Medical Something Act. I can't remember what it is, but liability it might be. Anyway, the bottom line on it is if you come to an emergency room, they cannot ship you out. There were some hospitals that were actually shipping patients out. A woman came in labor, you know, I think it was in Texas, in a hospital in Texas, and they wanted to ship her to the public hospital, and she died on the way, and there were lawsuits over it, and the law ended up being passed to keep hospitals from trying to dump patients. You know, that's basically what it was about. It also forces hospitals to make their medical staffs be available to patients who come in through the emergency room. But that doesn't mean they can't send you a bill, and that doesn't mean they can't pursue the bill. They can send you a bill. They can pursue the bill. Even if you go to the hospital, they can't deny you the care. So what happens is people often will end up going bankrupt. We know that you know, a substantial number of people end up in dire straits from medical bills. It's one of the main ways that people, more than half of personal bankruptcies have large medical bills as part of what's going on. Now, that may have changed that when that study was done, have changed a bit because now we got people going bankrupt over their houses. But you know, the fact is that it's a huge issue being able to afford medical care for the average person. And these bills can be huge. Yeah,
but, you know, going back to that, I think the figure they're still using is 62% of all personal bankruptcies. And another figure that has not been bandied about, but in those foreclosures, it hasn't all been the lending market that did it. 49% of those medical costs contributed a large degree to those home foreclosures.
Yeah, it wouldn't surprise me. So it's, again, big medical bills creating bankruptcy, even in people with insurance, because, you know, you get sick, you can't work, you lose your insurance, lose your insurance. Right. Now you got still sick, you got medical bills, you go bankrupt.
Okay,
vicious waterfall.
We see where the problem is coming from. What is the single payer system going to do for us? How does that actually work?
Well, a single payer is a pretty simple concept, actually. What we're talking about is taking all the money that we currently spend and put it into a single fund that's publicly accountable, and then paying the bills out of that single fund. The principal advantage of it is the reduction in complexity. One of the biggest flaws in our healthcare system is the complexity of its financing. If you look at the healthcare system, we have to have it, 70% of what we spend has to be spent almost ahead of time for the things that we want to be there.
That's true.
The hospital has to be built, yes. The doctors have to be trained, the IV poles have to be there, the gurneys have to be there, the beds have to be there, the nurses have to be there, on and on and on. So 70% of the costs of our healthcare system are basically fixed. They're there regardless whether one person comes, excuse me, or 100 people come. So one of our problems is that people don't recognize that if they want the healthcare, everybody's got to contribute to that 70% that's the basics, the bricks and mortar and the pieces that you want there when you get sick. So we have to support that infrastructure. And 70% of the money goes to that already. What we do is simplify the way that money flows, which is to say, rather than have a hospital bill for every aspirin, how about we just budget the hospital?
All right.
Yeah, give it what it needs every month to take care of the people who come in. No bills sent. That's how most of the rest of the civilized world does it.
Well, let me ask you this. Aren't hospitals built with a structure to make a profit on providing care?
Yeah, even the not-for-profit ones have a margin that they want to maintain because they have to rebuild their infrastructure again. If you can't buy a new bed or a new computer or, you know, some new things, new sheets for the beds or whatever, you've got to have a certain amount of margin. And There'd be no question about that, even in other countries where they do budget hospitals.
But isn't there an awful lot of competition between hospitals nowadays, and you see them growing and growing and growing and becoming so huge, and you have an MRI station in this corner for this hospital, another one across the street for that hospital.
Yeah.
Do we have a lot of duplication of services with the way we do things?
Oh, yeah. Actually, the best example of it that I read in one of the studies was the fact that we have about twice as many mammography machines as we need. And it's real easy to figure that out, right? Because we know about how many women there are. We know about how many of them are between the ages of 40 and 80 where you got to have a mammogram, and we know approximately how many breasts they have. And you do the math and you know how many mammogram machines you need, right? It's not rocket science. And we got twice as many as we need. Why? Because every radiologist's office wants to have one. Every hospital wants to have one. And the fact is that those are operating at about, half activity. They could, with half as many machines, we could still take care of all the women. And so what we're doing is have twice as much capital invested than we maybe need. And that goes back to maybe MRI machines and open heart surgery programs and yamada yamada.
Well, in some places we do seem to have an overabundance, but aren't there also underserved areas?
Absolutely. Yeah,
and why is that?
Money, honey.
Okay.
The places where there's the imbalance are often places where there isn't the money to support programs. I mean, I was just down in Southeast Ohio not that long ago, and one of our activists sadly passed away recently. And when I was first there, he took me around and just showed me, the rural poverty that was down there and how long it took to get from some of the places in Southeast Ohio to the nearest hospital that could even come close to providing care for somebody who was truly sick. And so, even in a state like Ohio that's fairly populated, you go out west, it could be hundreds of miles to get from some ranch to the small town, let alone to a big town where there might be sophisticated care. So we have imbalance that's geographic. We have imbalance that's poverty-based. There are healthcare deserts in big cities, just like there are food deserts in big cities.
Well, with a single-payer system, is there anything that this would do to help relieve that imbalance?
Well, you could reward people for going to those places. I mean, once we've made a commitment that we're going to try to to give the best care to everyone, and we want to keep our costs down, then it's in everybody's interest to prevent those illnesses that are preventable. And again, since we know that poor people have more suffering and disability from preventable illness, if we want to prevent those costs, then we better put doctors in the places where those people live and come up with programs to try and help. So we sure as heck want to have doctors where the trouble is, And so what happens is when you're paying everybody as if they're the same in a single payer, every single patient who comes through, the bum off the street, the president of the big corporation, they're all equally valuable to the healthcare system. So all of a sudden the systems will look and say, where are the sick people? Why? They're in the poor neighborhoods. They're in the poor rural areas. That's where they are. That's where the money is now. So it flips the whole thing. So the emphasis will change. There's actually some studies up in Canada when they became a unified healthcare system up there. The last province to come was Quebec. And what they saw is that the doctors literally switched from taking care of well-to-do patients more than poor patients to taking care of poor patients more than well-to-do patients once they had equal payment for every patient. So the doctors will do it. They'll find the sick people to work on. But right now we pay. They don't have any money. The poor folks don't. So.
Okay. That's really interesting, and I want you to hold that thought, and we'll be right back.
At eHarmony, you don't scan through thousands of pictures looking for your perfect match. Where's the value in that? We pre-screen each and every member for you to determine your matches based on compatibility. So when you get to that first date, you'll have something in common. eHarmony does the matching for you based on who you are at the deepest level. Aren't you curious to see who you'd be matched with? Log on to eHarmony.com, where it's absolutely free to review your matches.
May I help you?
Hi, I'm looking to save on car insurance, but it's got to be right for me.
Well, let's check out the Dave aisle.
Excuse me?
The Dave aisle, where your perfect policy is customized just for you. It's all here. The coverage you want, any discounts you get, all at a great price.
I have an aisle. Why is that guy in my aisle?
That's Steve. He works here.
Okay.
Getting just what you want at the right price. Now that's Progressive. Call or click today.
And welcome back to Healthcare for All, where we have our hosts, Debbie Silverstein and Dr. Johnathon Ross, that's attending today. We talk about a lot of things that single payer can actually do. But it seems like the one major player that's kept out of this is the insurance company. They don't like this idea then.
Well, I'm sure they don't. On the other hand, we do use them in our current one single payer piece of our healthcare system, which is Medicare. Mm-hmm. And what we have them do is we have them do something they do quite well, which is process bills. Now, Medicare, there's already a fee schedule for the doctors and there's a fee schedule for the hospitals. And their sole function in that is that bill processing function. It isn't their job to screen Medicare patients for who's sick and who isn't sick, to try to find just the healthy ones, and to make money that way. Their job is just to process the bills. So we use insurance companies, or what are called third-party administrators. Some very big businesses self-insure. And so the whole healthcare bill is going to be on them, but they use the insurance company to create a network of doctors and to negotiate some fees that are lower, perhaps. And but their main way they're making money is as a service to that business to process the bills. Okay. So there would still be room for that function within the system. Somebody has to process the bills. Now, hopefully, there'd be fewer of them. I mean, again, within single payer, one of the main ways we would save money is by budgeting hospitals. And if you budget a hospital, you don't have to bill for every aspirin. It really simplifies and reduces the administrative costs within the hospital. So there really wouldn't be much of that. That would be, a budget would be presented to some sort of publicly accountable authority or board who would review the hospital's budget and say, that looks right. We're looking, it's the right amount for nursing, right amount for drugs, right amount for your overheads otherwise. And here's 1/12 of it every month, and take care of sick people. See ya. I mean, that's how they simplify it. You save huge money that way. Perhaps as much as $200 billion a year could be saved just by budgeting hospitals.
Really?
Yeah.
Well, but
go ahead, Debbie.
Yeah, let's. I'd like to move into a more personal realm, though, especially for our listeners out there. As a physician caring for your patients, what would this do for you? Would this enhance your ability to care for them, and how?
Oh, excellent question. I mean, absolutely. I work, at least 2/3 of my time in a center city clinic that has a lot of uninsured people, and we're always trying to figure out how to make chicken soup out of chicken feathers. Mm-hmm. That's what we're doing. How do I get this person the care they need? How can I cobble this together? Mm-hmm. And so my life is very complicated by the fact that I can't get consistent access to the things that people need there.
But what about your insured patients? Is there any benefit to them too, or any benefit to you for your insured patients?
Yeah, because my insured patients often have significant problems with being able to see the doctors they want to see. They have to play Mother May I with an insurance company that has a limited panel of doctors, and they'd really like to be able to go to this doctor over here, but they can't. It's not on the panel. So within the single payer, you can go see whoever you want. You want to go to the Mayo? See ya. Go to Mayo. It's a long trip. I don't know for some things if I'd go there, but you want to go? Adios, Hopefully they'll take good care of you there. I mean, that's the beauty of it. And Medicare actually has that now. If you're a traditional Medicare patient and you want to go to the Mayo Clinic, or you want to go to Johns Hopkins or Harvard to have some specialist look at you, and you can afford to make the travel, you can go. Mm-hmm. No one's going to stop you unless you've been a Medicare patient in one of these Medicare managed care programs, and then you might get limited. But
that's Medicare Advantage.
Yes, the Medicare Advantage programs. Mm-hmm. Now, go ahead.
Well, we have a question from a listener. Mm-hmm. This is from Sophia in Lorain County, and she says she has 2 questions. The first one is, I work hard for a living. Why should I pay for somebody else's health insurance?
Because they're paying for yours. One way or the other, we all end up paying for it. As I was talking about before, 70% of the costs, at least 70%, are for infrastructure, for having the hospital, the doctors, the nurses, the equipment all ready for you. If only rich people can have health care, there'll be one hospital in Columbus, and even the rich people will die before they get there. So the fact is if we want to have these services available everywhere, we all have to contribute. We all have to kick in. And so, yes, I know you work hard, but lots of other people worked hard all their life, and now they're on retirement. Or there are people through no fault of their own who are completely and totally disabled. Are we just going to say tough on them and let them die, like we heard from some of the Republicans on their Tea Party debate the other night?
Mm-hmm. Well, the other fact, too, is that some of these other people are working very, very, very hard, but they don't have the coverage that some of us are lucky to have.
Very true. That, as a matter of fact, 75% of the people who are uninsured right now, of the 50 million Americans who are uninsured. The Census Bureau numbers just came out. It's 50 million Americans. Of that 50 million, about 75% of them are working people and their kids. They're in jobs that don't provide insurance, or the premiums are so high that would be taken out of their salary they can't afford to take care of their family with that. So 75% are there, and another significant chunk are folks that are out of the workforce, perhaps for reasonable purposes. Maybe they're an early retiree, but they don't have health insurance as part of their retirement package, or maybe they're a homemaker, who is not covered by the husband's policy because it only covers the worker themselves, or maybe it's like the students now. The new law has actually permitted students to get onto their parents' policies, and actually that's one of the few places in the census stuff where the number of uninsured went down was because we actually said that kids could stay on their parents' policies till 25.
Well, sometimes what happens is people are covered under a retirement policy, but then the cost of that policy, especially when you're dealing with retirees, we're talking about, older Americans, but the costs get very prohibitive, and sometimes those policies are just dropped. You retired with the knowledge that you were going to have this benefit, and then it's gone, and you're not eligible yet for Medicare. Sophia's other question is, what insurance company will Ohio use for this plan?
I guess I would let them bid for it. They're the ones that love the market mechanisms. I'm not for market medicine, but I guess I'm for market third-party administration for our system. So you could have them bid. On the other hand, we've already talked about, at least on our single-payer plan, about how it ought to be regional. We want there to be intimacy. We want the people that are making decisions about what healthcare services should be available in the community to be people you might bump into on the street, and you can say, hey, wait a minute, why don't we have a program for autistic children here in Northwest Ohio or whatever? So this is a sort of communication that I think could go on with a locally accountable board that could be elected or appointed, by other elected officials who would have oversight of the healthcare system. So each of those regions in Ohio probably has enough people in it that it would be of interest to an insurance company to be the third-party administrator. We're actually talking about using the appellate court regions. And, if you have 1 million people that you're going to be paying bills for, some insurance company is going to be interested in that work. And we got 11 million people in Ohio. So my guess is that we could probably bust it up and feed a lot of mouths that way if we wanted to do it. We wouldn't have to just, do it with one, although it might be more efficient to do it with just one. I mean, that would be a political decision, I guess, about what to do with regard to that.
And we want to thank Sophia for the question. And to our listeners, if you have a question, call us at 1-800-921-2204 and ask your question of Dr. John or me. Or you can also email your question to wcanradio@yahoo.com.
I have a question.
All right, go.
The self-employed and the uninsured, right now they're in a really difficult spot, They find it hard. A lot of them just don't have the insurance. And I'm talking about the self-employed. It's just way too high.
Absolutely.
This plan is also going to include them and make it so that they can reasonably afford insurance?
Yeah. The simplest way to collect the money is through taxes. Oh, I said the T word. Oh my
yes,
God.
you did.
I said the T word. Oh!
They're coming after you.
I'm in a church, too.
Yeah.
Said the T word. Anyway, but that's what's simple. You don't have to hire one more tax collector to collect the money. And to collect premiums, you've got to kind of service each individual that way rather than just have a general flat way of collecting the revenues. So the simplest thing to do is actually to have a tax that applies to everybody in a fair way. Even if it was a single flat number, that would be fairer than what we do now. So say if it was you paid 2% of your income and your employer paid 8%, or if you're self-employed, you paid 10% of your income. So if you're making $30,000, that's $3,000. You're making $300,000, it's $30,000. So you could make it progressive even to some extent with a flat tax. Or you could even make it completely progressive where the rich paid even a little more and the poor paid less. So, and we're talking about within this program, taking the current monies that already go to taking care of poor people, which would be like the Medicaid program and the S-CHIP program and Medicare, and getting waivers from the government to roll that all into one fund, and then paying pretty much equally to the doctors for whoever the person is, so that way everybody would have a fair shot at getting the care they need.
Okay, we do have a caller. Go ahead, caller. Go ahead, caller.
Hello. I have a question. This is Bob from Columbus.
Hi, Bob.
Since we now have a federal health care plan, why do we need a single-payer plan?
Well, sadly, although the federal health care plan will cover 30 million more, perhaps, at least that's the estimate, that leaves 20 million people out. So that's problem number one with the new health care law. Is it better than nothing? Yeah. The second problem is, if you were building a new layer on your house, a third floor on your house, and the foundation was completely rotten and crumbling, do you think that's going to work out? Because that's what we're doing here. We're talking about putting a third floor on a house with a crumbling foundation.
Okay, Bob, I hope we did answer your question. It seems like we lost you just now, but if you need to call back in, that number is 1-800-921-2204.
Okay. So I guess my thoughts on that question are, oops, should I keep on talking? I guess so. We got a little wiring problem here. So if we're talking about this whole issue of the new healthcare program, the second reason we wanted coverage wasn't just for the 15 million people who have none, and maybe we will drag 30 million more into this kind of rotten system, but we aren't going to control costs. We aren't doing anything. There's a whole bunch of ideas within the new healthcare law that maybe will help to control costs some, but we have a model that's out there already, which is Massachusetts, where they've done the same sort of thing, which is to kind of give subsidies to people to purchase insurance and give a fine to people who don't purchase insurance, and then use that money to help other people purchase insurance, the fine money. Mm-hmm. So that's kind of the way it goes. But the fact is in Massachusetts, their costs have been just steadily going up. And partly because all the complexity, the hundreds of different insurance companies, the hundreds of different programs, the hundreds of different levels of different coverage within that insurance, the different co-payments, the different deductibles, it requires an army of paper pushers and bureaucrats and billing clerks to chase all that down and figure it out. And what we need is simple. We need simple. So the real problem with what Mr. Obama and the Democrats did is they just built a third floor on a house with a crumbling foundation. And that crumbling foundation is the complexity of our private insurance form of financing.
Mm-hmm. Well, when you talk about the costs of the healthcare system and the fact that it doesn't reduce those costs or it doesn't hold them in, one of the things that we need to consider is the amount of our total economy that healthcare takes up, which is almost, it is about 1/6 now, and it's running towards 1/5. It's going to approach that very shortly. That has a large effect on our economy overall, doesn't it?
Sure. And you have to remember that when we devote that much money to healthcare and still leave 50 million people out, we're competing against other wealthy nations who have everybody in and are spending 5, 6, 7, sometimes as much as 8% less of their GDP on healthcare and getting equal or better results. And the data is out there. The Organization on Economic Cooperation and Development, the OECD, is a joint venture between America and the other Western wealthy democracies of Europe, Canada, Australia, New Zealand. And what they do is they look at the healthcare outcomes data and they look at healthcare cost data, and those things are built into being quite comparable, through economists looking at it and making those decisions. And we're at 16, 17% of GDP. And the second most expensive country, I think, is Germany now, and it's at about 10 or 11. And so when we're putting that much more money all the time, and we're talking hundreds of billions of extra dollars every year into healthcare that they don't, that's money that doesn't circulate in our own economy. It's money that we can't use to purchase other goods or to start new businesses within America.
Well, Jonathan, you've got all these templates that you just outlined in other countries that are making this, and it is a success.
Yes, sir.
Why, or what is the difficulty of making it happen here in America? I mean, there's got to be one underlying cause or several underlying causes that's causing this not to happen.
It's the money, sir. Remember that there are people who are very happy, thank you, in the current system. The pharmaceutical industry, $50 billion a year. The insurance industry, probably $15 to $20 billion a year. The equipment companies, $3 to $5 billion a year. The for-profit hospitals and nursing homes, $5 billion a year. I mean, that's their take. Why would they want it to change? You've got lots of doctors making lots of money. They know how to do it in this system. It's all set up. Why would they want to change?
Then what will it take to make it change?
You and Debbie and me and everybody else out there in listener land, hello. We got to organize. If you look at the history of social change in America, it takes a movement. It took a movement to get women the right to vote. Women went to jail. They starved themselves in jail. They chained themselves to the White House gates before they finally got the right to vote. Look at the Civil Rights Movement. What happened to people in that? Beat up, dogs, fire hoses, murdered, burned, hung. That's what it took. Vietnam, huge, massive protests. Washington, D.C. That's what it took. I don't know if it'll take that. I mean, we kind of made a step here. We elected somebody who actually wanted to do something about this and elected Democrats who wanted to work on it. But in order to get it passed, even what they got passed, they had to come up with a way to work with, the conservatives in Congress, many of whom are moneyed themselves and represent moneyed interests. So I think it takes pressure. I actually had a conservative politician, nice guy, I respect him, say to me, "John, make me do it. Please make me do it."
Okay. And yeah, that is, they don't want to stick their necks out. It was explained to me one time that the politicians and the people that we elect will only do what they feel that they have to do in order to get reelected. They're not going to take a lead on anything unless they think that it's something that they can run with and that they can win with. Okay. And so on this issue, we have to let them know this is something that they can win on, and if they don't get on board, it's something they could lose on.
And that's hard. That's hard work, and it's work I've been involved in. I mean, Deb's been involved for at least a decade, right? And I've been involved.
Well, not quite that long.
Well, but I've been involved since 1990, 20 years of this. When I started working with Physicians for a National Health Program, which is a physicians organization that supports this idea of an improved and expanded Medicare for everybody in the country, that was in 1990, kind of at the end of my experience with the insurance industry. And I decided I was rearranging deck chairs on the Titanic, Okay. And I really wanted to do something that would really make a difference. And at that point, Physicians for a National Health Program had just come into existence. They had published an article in one of the major journals about this idea of an improved, expanded Medicare for everybody. And I went to their first meeting, and there were probably 50 of us there. It was a small enough meeting that we had like a room with a table, and we could each have our little name in front of us, okay, as we talked back and forth in the room. And now there's 17,000 of us working on 18. And so I think that it is growing. And when we inquire of physicians whether they support the idea of an improved, expanded Medicare for everybody, we're hitting, at least among the primary care specialists and even some of the surgical specialists, we're hitting 50% or more, sometimes even 60 or 70%. Psychiatry, 70% support the idea. So I think we got the physicians coming around because we've been out as physicians talking about this. This very next week from this Saturday, I'm going to be at Sawmill Creek in Huron talking to the Ohio Association of Rheumatologists about this very idea, about what is the new healthcare law, the Affordable Care Act going to bring to us. Will it work? And whether we should maybe be thinking about single payer instead. Within the Affordable Care Act is a piece of it that says in 2017, states can, if they'll produce a program that'll cover as many people and not cost any more than the Affordable Care Act will, that the state can go forward with that program and should be allowed to have waivers. So that's within the law. Okay. We'd love that to be moved up. Right now there are 3 states that have already passed single payer. 3. Okay. Vermont, California, and Hawaii. Now, Hawaii is maybe the first ones. The Hawaiians actually got an exemption from a law called ERISA. ERISA says that you can't mess with businesses who do interstate commerce, that whatever their insurance arrangements are their business, the state can't regulate it. Not in Hawaii. So the state could actually bring everybody in a true way in the state of Hawaii. So, and we've got a governor in Hawaii and a legislature that's supportive.
Well, California, I didn't know that they had passed it.
They passed it. They couldn't get the governor to sign it.
Oh, okay.
All right. And now they've got a governor who says he'll support it if they pass it again, but they've got the crazy financing laws in California where for any kind of, they're going to raise taxes, rather than premiums. It might be this exact same amount of money that's covering everybody now in California, but they're going to have to do it with taxes instead of premiums. I don't care. For me, you take $5,000 from me for a tax or $5,000 from me for a premium. What's the difference? I'm out $5,000. At least I got my health care either way. But so I don't care which way the money leaves my pocket. But the fact is that in California, they have laws that say that they can't do anything with taxes without a public vote. And so that's a huge issue, is communicating that to the state of California. Now, the state of California is the size of Canada. It's like doing a whole other country.
Right.
So that would be a huge issue, but they're really well organized. Our PNHP chapter, what's probably our second biggest chapter, is in California. They went through an initiative, a state-based initiative in the 1980s to do single payer when the Clinton plan fell on its face. And they got hammered by the insurance companies and some other conservative forces, poured millions of dollars into a lie campaign about what the program would bring. And, of course, the single-payer forces had no money to really get back on TV or the radio or whatever else to talk about why this was a good idea. So it went down to pretty bad defeat, other than in San Francisco. The People's Republic of San Francisco.
Yeah, don't they have a universal health care in San Francisco?
They do. And actually, I was this is a fascinating little conversation. It's funny you should mention that, my dear. I don't know if I ever told you that story.
No.
I actually was sitting at an American Public Health Association meeting with a guy who helped to put together Healthy San Francisco. We were talking about a program that we had actually organized in Toledo, Ohio called CareNet. Some friends of mine and I who were health reform advocates put it together, and it's won national awards now. As soon as we kind of got it up and rolling and the hospitals took it over, they threw all of us progressives off the board. But it's still going. It's still giving free care to a bunch of people, so I'm kind of proud of it. But I had talked with this guy about what we were trying to do in Toledo, which was to say, look, primary care is cheap. Mm-hmm. You know, what I do is 10 cents on the dollar of healthcare is giving somebody a family doctor. Mm-hmm. 10 cents on, and basic labs, basic x-ray, that's 10 cents on the dollar to do that. And there's almost no excuse for not giving that to everybody, because that's where a lot of the prevention could happen, right? Mm-hmm. And so my argument was, why don't all the clinics in town just say y'all come, you know? We don't care if you have insurance or not, and then raise the money in the community to just cover that 10 cents on the dollar that's necessary to at least give them primary care. Maybe we can't put them in the hospital, but the hospitals were doing charity care anyway for the ones that were going to show up. If they're that sick, they're going to end up in the hospital anyway. So eventually they decided, well, yeah, well, why don't we just organize this whole idea? And we did, you know, made some proposals that were a little too liberal for the hospitals, and then they took it over and have been running with it since, which is fine. In San Francisco, they kind of decided to do the same thing, which was they said, gosh, you know, we've got a public hospital system in San Francisco that's pretty good. We've got a university hospital in San Francisco that's pretty good. All those faculty members are salaried already. They're there. Those specialists are there already. So for not much money, we could give primary care to all these uninsured people in the San Francisco County. And then if they needed the specialty care or the hospital care, well, they'll go anyway, but maybe we could keep some of those people out, you know, by keeping them healthy. Right. And so they ran with it. And one of the guys I spoke with, you know, about what we were trying to do in Toledo ended up going back to San Francisco and making it happen there. I don't know how he did it. One of these days I'll run into him at the Public Health Association meeting again and maybe ask him to tell me that story. But yeah, they're doing it with just minimal taxes on people who don't have health insurance as part of their business program. So the restaurants were one of the big ones in San Francisco, and they hated it. They were angry about it, but
people still go there to eat.
Yeah, and not only that, and people pay a little more to go to eat, and everybody who's working there now can get the health care they need and won't cough, you know, pneumonia into your food when they're serving it either.
Oh, that's kind of an important thing to think about, isn't it?
It sure is.
Well, let me ask you about this. What about those that are on the subsistence level where they're receiving Medicaid and food stamps and aid for dependent children? If this single-payer program comes into being, how will that offset their Medicaid? I mean, I know it will make it you know, opportune for them to go to hospitals and doctors of their choosing. Sure. But a lot of them have been on Medicaid for a while, and you know, it does the same thing.
Absolutely, and they may want to just stay with the very same providers, but the providers who are giving care to them will no longer be doing it at a cost to themselves. You know, if I were to, in my job, I'm employed by a hospital to run a center city clinic, and if that was my office, I couldn't stay in business. You know, they do it because they're taking other monies from people who pay for other services in the hospital and shipping them into the clinic because it's a Catholic hospital and has a charitable mission. They ship money there to support us while we give care at Medicaid rates. Right. But that's not right. Why shouldn't we be paid the same, you know, for the care? Actually, it's harder. I mean, I have a small private practice as well, and it's way harder to take care of poor people than it is to take care of well-to-do people. Well-to-do people have cars to get to their appointment. They got the money to get the medicines. They can get to the testing if they need to, you know, reliably. They've got education to help them understand the complexities of the things that I'm talking about. It's way harder to take care of the poor folks I take care of than it is to take care of the people who are more well-to-do and well-educated. And yet I get paid way more for doing the easy work rather than that hard work. So to me, that doesn't make any sense. At least pay me the same. Okay. You know? Okay. Now, so what we would do is take that Medicaid money and put it into one pool, and take the Medicare money and put it in one pool, and take the rest of the money that's going into private insurance and put it in one pool, and then kind of pay the same for everybody.
I understand that,
okay.
but what is that going to do for the individual that's on Medicaid, that is having a difficult time getting to the hospital, that is having, maybe doesn't have the education that's going to cause them to see what preventative care is going to do?
Yeah, absolutely, and that's even an issue now for people that have complete coverage on Medicaid and what have you. So we do have other issues. I mean, if you were to say, Dr. Ross, you're king, and in one stroke you can have one wish to reduce ill health in America to the maximum, one single thing, what would you do? And the answer is nothing to do with healthcare. It's eliminate poverty. That's the single thing that would make more difference for keeping Americans healthy than anything else. That's the other bad piece of news in the latest census,
right?
Is that the poverty rates are growing, and that's going to lead to more ill health. I mean, the fact is that more than anything else, what determines whether you're healthy or not is the social determinants. Were you educated? How were you raised? What were you exposed to when you were young? I mean, all those things probably make more difference as to whether you stay healthy or not. And there's really deep literature on this, excellent research on this in the public health. Even living in a poverty neighborhood, even if you're reasonably well-to-do yourself and insured and have all the things that you might need in life, just living in that neighborhood, you're less likely to be healthy. Whether it's the stress of being there, or the air is poor, or there's more toxins in the neighborhood, or whatever else. So eliminating poverty would be my wish. But short of that, what I can tell you is that once we're all in one boat and we've got one fund that we're all hoping to use to pay for things, boy, we're really going to come down to thinking about what should we be doing to really make this more effective? How about we get some nurse practitioners in schools, where the kids are, and work on their health there? How about we send some doctors into businesses where there's lots of people? How about we start focusing a little more on wellness and better eating habits and better exercise? How about we think about whether we had healthier communities where it's easier to walk without getting run over, making those things easier? Should we be paying for people who need exercise to have it? Right now, our healthcare system, somebody who's overweight and could benefit from a structured exercise program, they'd have to pay for it themselves.
That's true.
And it's going to cost us in the long run if we don't help them with that. So why not do what we can to help them be healthier? So once we're focused on that whole thing, the fewer people in our population who are sick, the better off we're all going to be, because we're all stewards of that pot of money. I think it changes your thinking about how to orient the healthcare system. It isn't, boy, I want to have all the heart patients. It's, boy, can we prevent all those heart patients? It's just a complete flip in mindset once we're all accountable for that pile of money that we all can dip into if we did, God forbid, happen to need open heart surgery. You want the money to be there for that? Well, we better, make sure fewer people need it, and then there'll be plenty of money for it.
Okay. We'll be right back after this.
May I help you?
Hi, I'm looking to save on car insurance, but it's got to be right for me.
Well, let's check out the Dave aisle.
Excuse me?
The Dave aisle, where your perfect policy is customized just for you. It's all here. The coverage you want, any discounts you get, all at a great price.
I have an aisle. Why is that guy in my aisle?
That's Steve. He works here.
Getting just what you want at the right price. Now that's Progressive. Call or click today.
Most of us look at the world like nothing bad will ever happen. An Allstate agent knows that all too often, it does. And they offer innovative ways to help protect your world. Like accident forgiveness, identity restoration coverage, and life insurance for the unthinkable. These days, you need more than just an insurance agent. You need an Allstate agent. Someone who makes it their business to help protect you. That's Allstate, Stan. Are you in good hands?
Welcome back to Healthcare for All. If you want to become a part of tonight's show, you can do so by dialing 1-800-921-2204, or you can send us an email to wcanradio.com. I'm sorry, that's wcanradio@yahoo.com. It's really an interesting show we have with us tonight, Dr. Johnathon Ross and our host, Debbie Silverstein. We want to thank both of you for being on here, but I want to continue this conversation because there's so much that I really want to ask, and I can imagine a lot of our listeners would also want to ask. Those that are denied health care, either, let's take, for instance, a special group, prisoners who have just been released from prison, incarceration. A lot of insurance companies don't want to touch them. because no telling what they've been exposed to while they've been incarcerated.
Absolutely.
You've got those that have pre-existing conditions. You have those with, we've got an increase in Down syndrome, mental retardation. How is this going to address that? I mean, everybody's going to be able to walk in and receive health care regardless of what their condition?
Well, that would be our hope. And again, as I said in the last segment, once you realize that you want to be able to do those things, to provide hope and services to people with tough to treat and provide services to tough to treat populations, it means that you better work pretty hard to prevent the common things that we know are preventable. Right now, in this country, the estimates are that 45,000 people die every year from completely treatable disease, principally because they don't have coverage. 45,000. And those people, a lot of them die not at home in bed. They die in our hospitals and our intensive care units using lots of resources when there was no reason it had to happen.
Oh, wait a minute. You mean to tell me they've got treatable conditions, but they're dying in the hospitals? Hospitals are not treating them, or is it?
No. It's they're so sick when they finally land. I don't know if you heard this week about the guy down in Cincinnati who died from a tooth infection.
No, I didn't.
Yeah, some poor guy had a bad tooth, and he went to the emergency room, and the emergency room looked at him and said, well, we can give you antibiotics and pain medicines, but you really need a dentist. He'd actually tried to get a dentist first, and they all wanted money on the table first, and he had none. ER gave him 2 prescriptions, one for a pain pill and one for the antibiotic. And he was in horrible pain, and he didn't have the money for the antibiotic. So he bought the pain pills and not the antibiotics. And the infection went to his brain, and he died and left behind a 6-year-old. That just happened this past week in Cincinnati, Ohio. Now, when I was an intern, I saw a man who was admitted to the hospital in Worcester, Massachusetts, where I trained, who came in with a bad enough tooth that had gone to his jawbone and completely abscessed his jawbone. And the doctors, he was on IV antibiotics. He was as sick as a pup, running fevers continuously. We were worried he maybe had a heart valve infection on top of it. He was sick in bed. And they were debating, could they even remove the bone that was infected, because it was infected so deep into his jaw, like they might have to take half of his jaw out, and he didn't want to have half his jaw out. He'd be disfigured, and there was all this stuff going on. And he'd been laying in bed so much he got a blood clot, and his leg went to his lung and killed him. Another guy, and that was when I was an intern 30 years ago. So like bookends here, okay? Bookends on my career. I was telling Deb and Heather over dinner this evening about a patient I had who had sleep apnea, who was a working man, 3 kids in his 30s. He was a manager, day manager in a McDonald's, and couldn't afford to purchase the insurance, for the extra he would have had to pay out of his salary with 3 kids. And he had severe sleep apnea. And I told him it was a dangerous condition and asked him to get it taken care of. And he didn't come back when he found out it would cost him over $1,000 to get the study he needed. And when he came back the next time, he was even sicker. It was scaring me. He was swollen and was going to fall asleep in the office every 2 seconds. He was so sleep deprived from his apnea. And we got a social worker over to talk with him. And we went round and round on all this. And the only way we could really get him the study and not have it end up in his pocket and break the bank for him was for him to quit his job, because with 3 kids he could go onto welfare pretty quick. And the social worker talked him into that, and so he quit his job. And while we were waiting to get the test scheduled, he died in his sleep. I mean, this is every day. I'll tell you, every day I see a near miss. Every month I see a wounding, and every year or 2 I see a story like the ones I just told, and those are real stories.
Now, you've told us these 3 stories. That means there must be thousands across the country.
45,000 every year. There are people who don't get their diabetes taken care of, so they end up with, even people who do a good job taking care of their diabetes sometimes struggle. But they end up with foot infections that go to the bone and go to the bloodstream, and they end up with an amputation, end up disabled or dead or blind or in kidney failure, and then die of complications of kidney failure. I mean, it's just routine to see people who are being eaten alive by their illnesses that had intervention happen soon enough, you wouldn't be at these severe endpoints with them. And they're very expensive. And remember, once you get really, really sick to the point you can't work in this country, completely and totally disabled, you get your Social Security and you get Medicare. So we wait until people are sick as pups, and then we cover them? What kind of sense is that?
Sounds a little
Let's
backwards.
Get upstream, man. Why are we way down here downstream? Let's get upstream.
Okay, we have an email from Joseph out of Elyria, Ohio. He says, I am a small vendor with about 8 employees. I want to expand my business with more full-time employees, but the cost of keeping someone on is enormous. Whether there is the Obama health care or the single payer's health care, I feel as if I am going to be the one in the middle paying more than my fair share. Mm-hmm. What would you be able to tell me that would convince me that your plan is just as good or better than what we already have? What can you present that will lower my cost of overhead and make it so that I can do more hiring?
Okay. Well, I think that's reasonable. And one of the things we have to look at is the difficulties that small business people have trying to be good employers of the people who work for them. Maybe I'll tell another story. My next door neighbor has a business where he kind of takes old pipes and he can put like a new pipe inside of it, so you don't have to dig it all up, right? And this is a business that he was running, and he needed a plumber guy, because every once in a while that doesn't work and you got to dig down in that spot and at least fix the one spot before you do the rest of it. So you do need people that have plumbing skills, and he had a guy that was just the right guy, a perfect employee, and he was talking with him about it. Turned out his wife was really, really sick with very expensive problems. And as he's listening to the story and he's thinking about this is the perfect guy to hire, he's thinking to himself, I better not hire him, because what's going to happen to my other 12 employees, because this is a small business, to our insurance policy when this guy becomes a member of our group. Now, that's the kind of awful decision that small businessmen like this guy have to make. And so I would think that, remember, this is all going to be publicly accountable, and we know that small business is the engine of the economy, and that's where most of the new jobs are created on a yearly basis. So we would certainly want to make it easy on them. What we were proposing was a tax that would be reasonable for somebody like this, and rather than pay a premium. And so if he actually thought to himself, well, how am I going to afford $10,000 per employee for eight people? That's not in the cards for me. It's a little bit like if you needed 2 telephones and you needed really 2.5. You can't buy the extra half telephone. Right. You have to buy the third one. Right. I mean, it's the same problem here. You can't buy portions of health insurance, or you can try by making your employees pay for it, but if they're not highly paid, they're not going to be able to afford it, and so they're not going to get what they need anyway. So within the program, we're talking about taxes that would be adjusted in a way to make it easier for somebody like this to be able to afford to pay their fair share, and it would be fair.
Yeah, and one of the problems that's happening today in business is that with the employer-sponsored insurance that we have, those costs, not just to small businesses and medium businesses, but also to large businesses, are becoming prohibitive. So what they're doing is they're passing those costs on. They still want to provide the benefit. They pass those costs on to the individuals, and eventually it gets so expensive that the individuals decline the coverage. Right. And that happened to a lady I know. It was either the health insurance or the house, because they were paying $2,500 a month for their health insurance at that point in time. It's getting to the point that no business can afford it. It doesn't keep us competitive with the rest of the world as far as that goes. And even small and medium-sized businesses have to be competitive in a global economy. But one of the things with that, for him especially, the effort has been made to make it beneficial to small business. And I have a friend who's a small business owner who he has about the same number of employees, sometimes a little bit more, sometimes fewer. And he ran the numbers from the plan that we have in the Ohio legislature, and he ran the numbers from 676, the national bill, and I've given him the plans for the others, and he said totally doable. Totally doable. Yes, for him, he doesn't offer it right now. It's a restaurant, and most restaurants don't unless they're a large chain. But he said it would incur a price increase of the menu items, but it would be such a slight one. He says the customers would never notice it.
I would encourage this gentleman, who's the small business owner, to go to our website at spanohio.org, and all one word, SPAN, Ohio, all one word, .org, and to look, because we've got some funding formulas that are on there that have been proposed, and he can take a look at what we try to do for small business, and it's way more reasonable than trying to buy an entire insurance policy for 8 people. The other thing is small businesses, because it's only 8 people, this is one of the awful things I had to do when I was an insurance guy. They would bring me a group of 10 or 15 people and say, well, this one had open heart surgery. Should we insure them? They're coming to me asking me, well, there's a chance the guy could end up in the hospital again. What's that going to cost us, and how does that fit into the premiums? I mean, I couldn't do that work. It's like, in the Roman days, thumbs up, thumbs down on somebody's health care. Cruel. I mean, I just had to get away from that stuff. But again, the basic function of the insurance companies in this world as it stands right now is to avoid the sick person. So in that case, he'd never have to worry about the fact that if he had one of his workers get sick, that it was going to poison his ability to give insurance to the other workers, which it could right now.
Right.
And the amount we're going to ask him to pay, we're hoping is going to be reasonable. So he cocould go to our website at spanohio.org and actually look and see what he thinks of our funding formulas, and he could even email in and talk to, email some of our activists that are online about these issues. To respond on it. We want to be responsive to business. We want to make it easier for businesses to get out of the business of having to worry about healthcare. Okay. I mean, that's the idea. You pay a tax and then you forget about it. You don't have to fuss with insurance companies or, negotiating every year or knowing what benefits or what network is or who goes to what doctor. You just pay your little tax and boom, you're out of there, right? Especially small business.
And that brings up another thing. The McCatchy.
Debbie, we're running out of time.
Oh, we are?
Yes,
okay.
we are.
Well,
this is so very interesting. I did want to make mention to everybody that the emails that we did miss, we will go over them on the next program. Now that it is every third Thursday of every month. So make sure you're tuning in again. I want to thank the both of you for having been on the show. Debbie, as our host, I tell you, you're doing a fantastic job. I think the movement is really great, and we hope to add to it by doing this show. WCAN is glad to, spearhead this issue of healthcare and provide you the vehicle that's necessary to make that happen.
Well, thank you, Eric, and we are very grateful to you for this. And I hope everyone would join me again next month when my guest is going to be Representative Mike Foley from the Ohio State House of Representatives, who is one of the sponsors of the Ohio Healthcare Security Act, the single-payer bill in the Ohio House.
And join us, spanohio.org. Join us.
All right. And until next time, have a good night.
Thank you for listening, and join us every third Thursday of the month from 8:30 to 9:30 p.m. Eastern Standard Time on Healthcare for All. Until next time, stay healthy.